The era of the chatbot is ending. Over the last few years, clinical discourse has focused on large language models as conversational interfaces, tools to summarize notes, answer queries, and draft things like patient letters. However, a fundamental architectural shift is underway. The industry is moving from chat to agents. We've done a short episode previously on the nature of Agentic AI, but in the last few weeks and months, and even last few days, there's been significant developments that I think it's worthwhile updating on with a bit more depth. The transition represents the move from AI that talked to AI that acts. This analysis examines the rise of Agentic AI, the significance of the Open-Clore Phenomenon, and the strategic implications for healthcare systems and professional practice. To understand the current shift, a technical distinction is required. A standard large language model is a predictive text engine. It responds to a prompt and stops. Agentic AI, by contrast, is a system where the LLM is given a goal, a set of tools, and the autonomy to loop through reasoning steps until the goal is achieved by using those different tools. In a clinical context, a chatbot might summarize a discharge paper. An agent might then read the paper, identify the required follow-up appointments, log into a scheduling system, find available slots, message the patient with options, and update the GP record once a selection is made. It operates not in a single turn, but in a continuous execution loop. This brings us to an opinion piece by Matt Shumer called "Something Big is Happening in AI," which has drawn a lot of attention recently and might blindside most people. He describes this as a February 2020 moment for AI. Just as the global landscape shifted rapidly during the COVID pandemic, the technological landscape is currently undergoing a nonlinear acceleration. The gap between what the public perceives AI can do and what is currently being executed in technical environments has reached a bit of a critical threshold. Shumer's thesis is that the current evidence suggests that AI progress is no longer incremental. In early 2025, new training techniques unlocked a faster pace of development. The primary shift is the move from guiding the AI to describing the outcome. In software development, which is often a leading indicator for other white-collar sectors, the workflow has fundamentally changed. Developers no longer use AI to write a single function. They describe an entire application's purpose, design, and user flow, then allow the agent to operate autonomously for hours on end. These agents now write tens of thousands of lines of code, open the application, click buttons to test features, identify bugs, and iterate on the design without human intervention. The human returns not to a rough draft, but to a finished, tested prototype product. This outcome-based model is the blueprint for future clinical administrative work, potentially. The prediction from industry leaders, including Anthropic's Dario Amodei, suggests that up to 50% of entry-level white-collar tasks could be automated within 1 to 5 years. This isn't because one specific skill is being replaced, but because AI is becoming a general substitute for cognitive coordination. The most significant signal of this shift is the explosive growth of OpenClaw. Originally an open-source project by developer Peter Steinberger, OpenClaw, formerly called ClaudeBot, became one of the fastest-growing software projects in history, amassing over 145,000 GitHub stars by this month alone. OpenClaw is an autonomous agent that runs locally on a user's computer hardware. It's granted root access, the ability to control the computer's file system, execute shell commands, and interact with any application on the computer. It integrates directly into messaging platforms like Slack, Teams, WhatsApp, and iMessage. Anthropic also released agentic products able to automate a lot of legal workflows. The market reaction to these developments has been immediate and profound. Software stocks saw $1 trillion valuation wipeout as investors realized that traditional software as a service, or SaaS, models are potentially vulnerable to agents that can simply do the work across existing interfaces. The strategic importance of the technology was confirmed when OpenAI moved to acquihire the OpenClaw team, pivoting their entire corporate strategy more towards this kind of agentic execution. Now, there's been a lot of debate about exactly how profound these changes are and how easily you can replicate embedded complex software packages that are provided by a lot of companies with autonomous AI agents. But I think OpenClaw demonstrates 3 key things. First is the ability that there now is for local agency. Agents don't need to live entirely in the cloud. They can operate on local clinical workstations, potentially mitigating some data residency concerns. Second is the extensibility of skills. Through ClawHub, a registry of thousands of community-built skills, Agents can be rapidly taught to handle specific tasks, such as querying a specific electronic healthcare record or managing a particular insurance coding set, for instance. And third is autonomous coordination, the emergence of something called Maltbook, a social network where only AI agents post and interact, showed that agents can coordinate and share information without direct human oversight. Again, there's been some skepticism about whether there was actually some human oversight in these features, but it's been an interesting experiment nonetheless. While the Christopherianism AI religion that emerged on Maltbook is a quirk of the technology's mimicry, the underlying mechanism, agents executing shell scripts to update their own configurations based on peer interaction, is a radical new paradigm in system management. So what might the implications be for healthcare? The excitement of agentic AI must be tempered by the reality of data readiness. While the technology is ready, most health systems aren't. Research from Cisco and the World Economic Forum indicates that only 13% of organizations have the data infrastructure required for effective AI deployment. In healthcare, this manifests as the intelligence gap. Most trusts are data-rich but intelligence-poor. Data's trapped in disconnected silos. Marketing, clinical records, billing, and scheduling are all in different systems. An agent is only as effective as the data it can access. If an agent is deployed into a fragmented environment, it will not unify the data necessarily. It will simply scale mistakes with higher confidence. If the John Smith in the oncology system is not linked to the J Smith in the pharmacy system effectively, an autonomous agent will make decisions based on incomplete profiles. The World Economic Forum identifies 5 dimensions of readiness. First is unification, where there's a single source of truth across all systems. Second is quality, where you have deduplicated, accurate formatting of data. Third is governance, with clear rules on access and accountability. Fourth is real-time access, moving away from batch reports to live data streams that can be accessed and processed upon at any time. And third is accessibility, structuring unstructured data, things like PDFs and scans, ready for agentic consumption. Agentic AI introduces unique security risks that don't exist in standard LLM chatbots. Security researchers have labelled the Open-Clore model a lethal trifecta of risk. That trifecta comprising private data access, so agents have with deep access to sensitive files in the root of the computer. There's untrusted content exposure, so agents reading external data like a patient-sent email or an external lab report that might be vulnerable to something called prompt injection, where hidden instructions in text might hijack the agent's processors and autonomy. And third is persistent memory. If an agent is poisoned by a malicious instruction, that instruction can remain in its memory, affecting future autonomous actions too. For clinicians, this means the era of shadow AI, where staff use unsanctioned tools to manage their workload, might be entering a dangerous phase. A clinician using an unauthorized agent to summarize patient records could inadvertently grant the agent the ability to exfiltrate data or modify system configurations. So the window for being early is closing. To navigate this transition, clinical professionals with different interests should focus on 3 strategic pillars. First is a move from search to workflow automation. Clinicians should stop treating AI as a search engine. The value these days lies in pushing an AI into actual work. This means using the most capable models to handle complex multi-step tasks. If a task takes 3 hours of reading and cross-referencing, the goal is to use an agent to reduce that to 10 minutes of verification. 2 is focused on licensed accountability. As agents take over our cognitive work of reading, writing, and analyzing, the human role shifts to accountability. AI might be able to draft a treatment plan in the future, but it can't hold a medical license or stand in a court of law. The future of the clinician is the clinical auditor, the expert who signs off agentic outputs. Roles that require physical presence or licensed responsibility are the most resilient, but the nature of the work within those roles may well change entirely in the not too distant future. Third is to think about data foundations now. For hospital managers, the priority isn't necessarily buying the flashiest agent, it's about fixing the data pipeline, the basics. 72% of business leaders are now prioritizing data foundations as the fastest growing investment area. Without unified patient intelligence, agentic AI will be a liability, not an asset, or just simply unusable if it doesn't have data. Agentic AI is a fundamental departure from the tools that we've used over the last decade. It represents a potential transition from software that supports us to software that acts on our behalf. The OpenClaw movement and its subsequent acquisition by OpenAI confirm that the industry's North Star is now autonomous agency. A lot of the frontier labs are focusing on developing tools that are very good at coding so that they can do this exact type of agentic workflow. While software stocks have fluctuated and security concerns are real, the trajectory is increasingly clear. The most valuable person in the clinical environment will soon be the one who knows how to orchestrate a fleet of agents to handle the drudge work of medicine, leaving the human to focus on the high-stakes judgment that no script can replicate. The real power from agents isn't just from getting one agent to do a task. You can literally have thousands or millions running to automate all manner of projects, if compute access allows. The future hasn't knocked on the clinic door yet, but it's already in the building. The advantage belongs to those who start experimenting today. If nothing else, it's just really interesting and cool to play with these tools. We'll be sure to cover any important updates on Agentic AI and how they might be relevant to healthcare, so if you would be interested in hearing that, then don't forget to hit like and subscribe so that you don't miss future episodes.